The earlier the intervention is to retard the forward growth of the upper jaw, the more the whole face is going to end up being retracted in the long run. You basically trap the lower jaw. You end up with a face that looks like a big nose and no chin, and usually very long. Uh, and with that, the airway is compromised because the farther back the upper jaw is, the farther back the soft palate is, which means that the airway in that region is diminished. The farther back the lower jaw is, the farther back the tongue is. Again, reducing the airway. So it's the last thing we want to do for anybody.
And could that cause sleep apnea?
In my opinion, it can absolutely, and there's evidence in the refereed literature. I think there's an article in 1989 that I cite in one of my lectures, which is questioning this whole thing and saying, "Gee, we shouldn't be using headgears in anyone who has a recessed lower jaw." Well, the fact is, everyone who's given a headgear has a recessed lower jaw. So the point is, why would you use a headgear on anyone?
So, Bill, here's the scary part. We know that sleep apnea is life-threatening. It knocks off, 20 years in severe cases
Right,
off someone's lifespan. It causes people to, to die early, to not be
right,
able to work, to be on disability.
right.
So am I off base if I say that headgear is potentially lethal?
Well, in the long run, I think you're correct. I mean, look at it even in the short run. If you anything which is going to produce a lack of forward growth of the lower jaw is going to reduce the airway. Uh, and I mean, even in children, children have sleep apnea, and every night if they have apneic events, they're getting brain damage from that. Dr. Ron Harper, who's a PhD neurobiologist at UCLA, has shown MRIs with where the areas of the brain are damaged, even in one night of reduced of reduced oxygen saturation. So it's a big deal. It's something that happens very slowly for most people, but I think this is a thing that really the society needs to take a look at. And I haven't used a headgear since about 1982. And my patient population that comes to see me is no different now than it was then, but I treat them in an entirely different fashion. And everyone else could too if they just would do so. But what we have is, gee, it's always been done this way kind of a thing, and nobody seems to want to change.
Should people also be wary about temporary anchorage devices and the retractive effect that they have on the bones in front of the airway?
I didn't hear you.
Should people be also weary about or concerned about temporary anchorage devices and the retractive effect they
Right.
have on the airway?
I think absolutely people should be concerned. I don't ever want to see a temporary anchorage device used for retraction. I mean, it's commonly done right now, but no one seems to be asking the question, and it's certainly not required in the literature to look at the airway. It ought to be absolutely required for an article to be published in the literature. What is the effect of this treatment on the airway? It makes no sense at all to retract in any form. Retraction should be history in our profession. It should not be done in any way, shape, or form anymore. There's no excuse for it. I mean, I can't. How can anybody justify it? I don't know. In my lectures, one of the things I'll ask is, "Gee, how many of you think that you could retract and cause someone to have sleep apnea?" And everyone says, "Well, yeah, I agree. It could be done." My next question is, so how far can you retract before someone would have sleep apnea? And no one knows. And I say, well, I don't know either. I have no way of knowing. And so the obvious third question is, if you don't know where safe retraction becomes unsafe retraction, how can you comfortably retract at all? I
Hmm.
mean,
Bill, I thought about that. I did a little bit of math. So in some of the studies I was reading, um, the the writer says, and this is in the peer-reviewed stuff, the writer says, you know, that we are okay with a margin of error of 1 millimeter. So if I'm off by a millimeter, I'm within, whatever standard deviation we pick is okay in orthodontics. And then I look at the tongue, and if the tongue goes back just 1 millimeter, well, the airway has a 10 millimeter diameter in some
Right.
people, and on average 10 to 12. So a millimeter is actually 10% of your airway, but it's 10% of the diameter, which is a lot more than 10% of the actual surface area
Right.
for airflow.
My experience in reversing retraction has been, I've had a patient where I advanced the lower incisor teeth minutely, and it was a 40-year-old gentleman. He came in and said he is not snoring anymore, and insisted that his wife said he's not snoring, and I barely moved his teeth at all, maybe a millimeter. And it was really interesting, and I learned a lot from that case, and I've seen the same similar kind of thing happen in other cases. What's really compelling is when you understand Poiseuille's law, which governs the flow of a gas in a tube. The resistance to the flow of a gas in a tube varies inversely according to the fourth power of the radius of the tube. So retracting a millimeter, essentially, on that tube can have a devastating effect on a person's ability to breathe. Uh, I've been reopening extraction spaces now for people for 26 years, and I learned from every one of them. And the one thing that is crystal clear is that anything which reduces the airway, even minutely, is not okay.
Cool. Thank you, Bill. So we'll stop now, and we'll do the next one.
Okay.
Okay.